SolRx Incorporation and its review programs are neither related or endorsed by Pharmacy Examination Board of Canada, which is also known as a PEBC. SolRx Incorporation does not provide any certifications. PEBC is a trademark of Pharmacy Examining Board of Canada and is not related to SolRx Incorporation.
But so today we'll be talking about primary and secondary prevention of cardiac disease. So remember, as a pharmacist, in school, we're always trained to focus on how to treat something, right? Okay, if somebody has an infection, how do we treat it? But now we play such a big role in prevention of cardiac events and other things that occur. But in pharmacy, you also really have to understand, based on the patient factors, what you can do for them. So before we jump into this, I wanted to go over a few definitions with you. Do you guys, and be honest with me, do you guys understand the difference between cardiovascular disease versus atherosclerotic cardiovascular disease versus ischemic heart disease versus coronary artery disease? Do you understand the difference between those? And if not, that's okay, because then I can go over that. Because you have to really understand these words, and if you don't, then on your exam, it can cause a lot of confusion. So do you guys know a little bit? Don't know? Tell me where you're at with that. A little bit? Okay. Okay. Any more comments? 50-50? Okay. Okay. So you guys are okay if I go over it? We can talk about it? All right. Perfect. So I like to think of cardiovascular disease as the umbrella term. So let's write cardiovascular disease. Cardiovascular disease. This is your umbrella term. It could be anything related to heart attack. It could mean stroke. It can mean heart failure. So think of it as the tip of the umbrella. Okay. Under cardiovascular disease, we have something called atherosclerotic cardiovascular disease. But what does that mean? What's this fancy A? What does atherosclerotic mean? Atherosclerotic means clot. Okay? So when we look at this word, we're saying, okay, cardiovascular disease related to a clot. So this is one type of cardiovascular disease. Does that make sense? What I just said, does that make sense? So this is your broad term. And then atherosclerotic is clot-related cardiovascular disease. Okay, great. So we're on the same page. So now let's elaborate just a little more on this. What are the different types of atherosclerotic cardiovascular disease? Do you guys have any idea? So what are some clot-related heart diseases? Very good. We have coronary artery disease. We have very good stroke. We have peripheral artery disease. Exactly. Very good. What about deep vein thrombosis? Do you think that counts too? Yeah. Yeah. Deep vein thrombosis. Very, very good. Okay, so these are all clot related. Now, let me ask you this. We just said that atherosclerosis is clot. There's another word we commonly use for clot other than atherosclerosis. Do you guys know what that is? Ischemia. So ischemia also means clot. So plaque emboli, you're right, but ischemia and atherosclerosis both mean clot. So why am I telling you that? I'll explain. When we look at coronary artery disease, there's another word that means the same thing that a lot of people get confused. So coronary artery disease is also the same thing as ischemic heart disease. These words can be used interchangeably. Does that make sense? Do you see why? So we're talking about clot in the coronary arteries, which is coronary artery disease. Okay? And then when you say ischemic heart disease, you have a clot in the heart. So these words are used interchangeably. So if you see one or the other, they mean the same thing. And if you don't understand, say, Farah, I don't understand. And that's okay. Does that make sense? That's very important. Makes sense? Okay, very good. Now, what's an example of coronary artery disease, aka ischemic heart disease? Give me an example, guys. What's a good example? So now we're thinking of just the heart. Am I? Uh-huh, uh-huh, uh-huh. So myocardial infarction, STEMI and STEMI, uh-huh. Very good. Very good. You have unstable angina. You have angina pectoris. Very good. Very, very good. So STEMI and STEMI, unstable angina. Perfect. Okay, so now you nailed this definition. But now I want to make our way back to the top for a second. Let's go back to cardiovascular disease. Okay. Where does heart failure and AFib come into play into this? Is the pathophysiology of heart failure related to clot? Can you say that heart failure falls here? No. Very good. So where does heart failure fall? Does it fall at the top? Does it fall up here? It's about ejection fraction. Exactly. So you can say it is a type of cardiovascular disease. So heart failure is a type of cardiovascular disease, not related to clots, but is a type of cardiac disease. Do you agree with this statement or no? And if not, that's okay. We can talk about it. Yes. Very good. Now, what about one more? AFib. Where does AFib go? Does AFib caused by a clot? Very good. Very good. Okay, very good, guys. Exactly. So AFib is also at the top because it is not caused by a clot. I mean, clots can happen as a result of it not being managed properly. Exactly. Very, very good. So now I'm assuming this fully makes sense. Are there any questions about this? Now, do you feel you understand it? This is very important. Yay! Okay, awesome, wonderful. I'm going to clear this slide and then I'm going to write a couple more things for you for us to chat about. When we look at cardiology trials and when we evaluate studies to say, okay, there's a new drug on the market and is it really going to work for the patient? Why or why not? What do we look for and how do we interpret them? The first thing I like to talk about is soft versus hard outcomes. And some of you who've known me and mortality benefits, some of you who know me will know part of we've talked about this in the past. So I'll go over it very briefly. So there's something called soft outcomes. Okay. versus hard outcomes. Let's say a fancy drug just came to market, okay? A fancy new statin came to market. And the studies say this drug is so good and it lowered the LDL by like 100%. It's like a brilliant drug. Would that be a soft outcome or a hard outcome? Do we care about how low the LDL levels are? You remember, very good, exactly. Do we care about how low we can get the LDLs at the end of the day? Yeah, LDL levels are important. Yeah, for sure they're important. But at the end of the day, what are we looking for? What are we looking for? We want that reduction in LDL to reduce the chance of heart attack, right? Heart attack and death. And then I'll tell you why I'm telling you this soon. But essentially, when you have soft outcomes, so blood pressure, LDL levels, it'll give you an indicator of, okay, the drug is good. But when you're looking at the trials, we're trying to figure out, is there death prevented? Is there heart attacks prevented? And this, why am I telling you this? Because this ties to when you talk to your patient and you tell your patient, make sure you take your blood pressure medication. Okay, well, Farah, I take my blood pressure medication because it lowers blood pressure. And then I always ask my patient, but what does that mean? What does it mean to have lower blood pressure? They'll say, I don't know. I don't know. We want to prevent cardiac events. We want to prevent atherosclerotic cardiovascular disease. We want to prevent the heart outcomes, which is death as well. Does that make sense? So you have to be very mindful when you're reading information on your exam and when you're interpreting things that you're not hung up on these numbers, but you're looking at the outcome. Does that make sense? Because this will lead into my next point. I know I'm giving you bits and bits of information, but this leads into my next point. But does this make sense? Are you with me? Okay. So this leads into the next point of primary versus secondary prevention. Is that the same like endpoint outcome? Yeah. So the endpoint outcome that we're always looking for is preventing atherosclerotic cardiovascular disease, like heart attack and death. Yeah, your LDLs, your blood pressure, it's important to manage these risk factors, but ultimately, the hard outcomes is what we are looking to prevent. So now going to my next point, we're going to draw something else. We're going to draw a table called primary prevention versus secondary prevention. This one is very important. When we look at the trials, when we are evaluating patients who are in the hospital, out of the hospital, the first thing we have to figure out is, okay, do they have risk factors for cardiac events, right? But have they experienced any cardiac event as well? In primary prevention, this means that you may have a patient with high cholesterol, high blood pressure, but they will not have experienced any atherosclerotic cardiovascular disease. So maybe they have like hypertension, but no MI, no heart attack. Okay, they may have high cholesterol as well. But in secondary prevention, these patients already had experienced, let me put a bit down here, had MI, had a stroke. And now we want to prevent the second occurrence. Does that make sense? Primary versus secondary. I'm just trying to high level go over different definitions for you to understand at a high level today. Yeah, okay. Very, very good. So when we are looking at trials, when we're reading informations about the patients, just be very mindful that yes, high blood pressure, cholesterol, these soft outcomes are very, very important, but your eyes, when you're reading the case, have to look for, do they have a heart attack? Did they have a stroke? Do they have peripheral artery disease? What are the hard outcomes? What are the atherosclerotic events that they have experienced? If they've had a heart attack, if they've had a stroke, then we have to put them on more medication. You guys are okay? We go back to the slide now. Does that make sense? We're good? Yay! Okay, wonderful. Okay, so this is a summary of what we just talked about, so I'll go over it with you briefly, and as you know, you will have access to this and you can read it at your time. So remember, cardiovascular disease, think of it like your umbrella term, right? Your umbrella term, it encompasses everything. Clot-related heart disease, heart failure, atrial fibrillation, and it is the leading cause of death, causes hospitalizations and impairment of life. And we know that under the umbrella term of cardiovascular disease, we have atherosclerotic cardiovascular disease. So now we know we have ASCVD, which is a type of cardiovascular disease. And then remember, primary prevention. Primary prevention is we want to prevent the first occurrence of cardiac disease. First occurrence. So they'll have high blood pressure, high cholesterol, but they'll never have experienced a heart attack. Secondary prevention is okay, it happened once. We need it to not happen again. And how do we manage all this? Medication and lifestyle changes. And believe it or not, lifestyle changes in cardiology have a big impact. I know in some conditions, non-drug measures are like, but in cardiology, they play a very, very big impact. So we should not neglect it. And to answer the question online, for a patient who had a heart failure, do we go for a secondary prevention or primary prevention? Very good question. For somebody who has heart failure, they're still considered primary prevention. They're considered primary prevention because this is not a clot-related disease. Because it's not a clot-related disease, we're focused on still primary prevention. Very, very good question. Now, what about cardiac risk assessments? The students will always say to me, "Fine, do I have to memorize these risk assessments?" You do not have to memorize them, but you have to understand what puts the patient at risk of cardiac events, okay? Do they exercise? How is their diet? But remember, when it comes to physical activity, you cannot say like, oh, okay, they walk, they're healthy, or you have to say, what is their baseline? And have they improved from their baseline? Like I remember I was a preceptor, we had a student, and the student was learning how to ask questions. And I still remember the patient was in a wheelchair. And then the student says, like, what's your physical activity like? And do you walk and things like that? And I'm like, oh, no, you can't say that, right? You have to look at the patient's baseline. If they can't walk, maybe they do other arm-related aerobic activities. Are they a runner? Is that their baseline? What is their baseline and how can we improve their baseline, which is very important. What is their baseline use of alcohol and tobacco? Do they have a parent or a family member that had a heart attack early on? Like, did the patient have a father who had a heart attack before the age of 50? Was it a premature cardiac event? Because that automatically doubles the patient's risk of developing an event. You want to also look at the patient's BMI. You want to see their weight. Are they overweight? Because their weight can affect other things like osteoarthritis and other things. Screening for cholesterol as well. So there's a lot of different things we have to look at, but ultimately it's the patient's baseline. And another tip for you on your exam, you will realize that all the options, as you know, you're given 4 options, it is likely that the 4 options all may be correct. And I've said this to you guys before, the 4 options may be correct, but which one is the most correct for the patient? So if you have a patient who has issues with all of these things at the very bottom here, has an issue with all of these, high cholesterol, smoker, high blood pressure, all of it, you have to ask the patient, what is the one that we can tackle first that you think is realistic? So the patient will say, you know what, maybe smoking less will be more realistic to start with. And that could be the answer for your exam. So smoking cessation, pharmacists can prescribe for that. We'll be covering it much more detail in the course. And when it comes to quitting smoking, I always tell patients, it's not a one-time thing where you start the medication and you're guaranteed to quit. Sometimes it takes multiple attempts and motivational sessions to help patients quit. Diet is also very important. So Mediterranean diet, extra virgin olive oil, fatty fish, salmon, less red meats, fruits and vegetables is also important. One thing I find that's helpful for patient is starting by reducing their sugary drinks, so dealing with the liquids first before going to the solids. But you'd be really surprised when I sit with patients. One of them told me they went to their endocrinologist, and their endocrinologist went to the Diabetes Canada website and printed an info sheet about diet and said, here you go. And then the patient came to me and he's like, it said rice is not good for you. So the poor patient cut out rice completely. And I said, okay, but that's not the way you should be changing your diet. So a lot of it is education and working with the patient, not just saying, okay, eat this, and avoid this. Physical activity is also important to work with the patient to something that is suitable for them. Some people will prefer starting with 1 day a week, 30 minutes a day. Some people prefer more high intensity. So it really depends on what your patient is looking for. And then these are your targets for alcohol consumption. Of course, we want to minimize it as much as possible. But if somebody has 3 drinks a day and you bring it down to 1 drink a day, that's fine as well. Don't get very hung up on the numbers. Look at the patient and say, okay, this is what they're doing before. This is what they're doing now. And if there's an improvement there, that's a big win. Okay. How are you guys feeling so far? Just checking. Does this make sense? Because I'm just talking, but I want to see, do you see the mindset? Because I want to show you how you should be thinking when you're reading these types of things, where it's not just, okay, memorize, but how you have to do it in a very patient, specific approach. Does that make sense, guys? We're good? Yeah, I know it's late. Yes. Okay, perfect. Yay. Okay, wonderful. Good. Okay, now looking at hypertension. You know, blood pressure is a tricky one because anything you do can change your blood pressure. You stand up, your blood pressure changes. You sit down, your blood pressure changes. You drink caffeine, your blood pressure changes. You go to the doctor's office, your blood pressure may skyrocket, right? You may get the white coat hypertension. So I always encourage patients to get a blood pressure monitor at home because home is your natural environment and then you can get a good reading. I always tell patients, take 3 readings, discard the first, and then average the second and the third reading. Patients don't fully understand the value of that. I remember at the pharmacy, a patient came in and she's like, I was just at home and my blood pressure was like 180 and I wanted to come measure it with you at the pharmacy. And I said, okay, let's sit down. So we sat down for 5 minutes and we tried to decompress. I took her reading, it was like 170. And I said, wait 10 minutes, just sit here, don't do anything. I'll come back in 10 minutes and we'll measure again. And then it dropped. It dropped to like 150. So you always have to take multiple readings. And so why am I telling you this? On your exam, never trust the first reading you see. Always question it. Did they have caffeine in the last 30 minutes? Did they smoke? Were they just running up the stairs and now they sat down? Were they talking during their reading? You always have to critically think about these things, because that's going to help you pick between two options. Because as we know, there's always two options on the exam that are super close and it's hard to pick. But this is what will help you. And then, of course, you can read up and you'll see here, and we'll explain more in class, the lifestyle changes, reducing the salt intake, and then increasing potassium if the patient is not using medication, prescription meds that increase potassium. Next is diabetes. It's really interesting now because I'm starting to see very young patients diagnosed with type 2 diabetes. I had a 30-year-old come in diagnosed with type 2 diabetes, and it wasn't even like he was overweight. He didn't have any other issues. He's just like an average person, and he's like, I have type 2 diabetes. And I'm like, what? And he's just starting on metformin. Things are changing a lot, and it's very surprising. So you have to be very open-minded that not everybody who's older will get diabetes. I'm seeing people in their 30s. Few rarely in their 20s get it too. So a lot of it is education, and helping the patient. And even when it comes to treatment of these patients, don't always say, okay, yeah, metformin. Some patients don't want it. I had a patient, the A1C was high. The A1C was like 10. And I'm like, okay, we should start treatment. And he's like, I don't want it. And he's like, I don't want treatment. If somebody says you don't want the medication, like how would you guys handle that? If you have a patient with an extremely high A1C and they get a prescription for metformin and they tell you they don't want it, what would you do in these situations? What would you say? Any ideas? Anything. And if you don't know, just say, Farah, I don't know. Because I'm okay with that too. Educate. Let's say the patient says, yeah, I know the risk factors. I know what diabetes can do to me. I don't want the meds. I don't want the meds. Lifestyle. Exactly. You will never be able to force the patient, because you know what? He can take the drugs home and throw it in the garbage, right? So be very careful on your exam when you're reading a situation. If you see the A1C skyrocket and you say, okay, we have to start them on insulin, we have to start them on diabetes meds. No. What does the patient want? And a lot of times it may go against the recommendation. And so you have to also be mindful of that. So again, a lot of this primary, secondary prevention, a lot of it is education, and assessing what the patient wants. Very, very good. Good. And then next we have is high cholesterol. That is a very common one. You'll see almost every patient using a statin medication. Non-drug measures are helpful, and drug therapy is also helpful. And be mindful, and we'll discuss this more in class. But we tend to forget, and even patients forget, that you don't need to have high cholesterol to be on a statin. Does that make sense? Your cholesterol levels do not have to be high for you to be on a statin? Can you give me an example? What do you guys think? Give me an example. What are the situations where you can have normal cholesterol levels but require a statin? Very good. Secondary prevention. Very good. So if somebody had a heart attack, right? And we want to prevent another one, whether or not they have high cholesterol, we start them on a statin because of the heart outcome benefits, the mortality benefits. Exactly. What about, let me ask this, what about somebody who's never had a heart attack, but they have diabetes? Any thoughts? No heart attack, but they have diabetes. Should they be on a statin? Yeah. If they are 40 years of age or older and they have diabetes, they should be on a statin. And this gets missed all the time because these patients are at much, much higher risk. Yeah. Okay. And we'll be covering this more and more in detail in class. This is just more of a primary versus secondary prevention, but exactly. So there are instances where patients should be on a statin regardless of their cholesterol levels because of the mortality benefits, the hard outcome benefits. Very good. And then just looking at the bottom of the slide, the Framingham risk. You don't have to memorize this in detail. Just understand that there are so many different risk assessment tools out there that take the patient's personalized values, put it into a calculator and say, okay, in 10 years, this is your risk of a heart attack based on your age, your cholesterol, your blood pressure, your lifestyle. This is what your risk of a heart attack will be. Now, this is where it gets interesting. A lot of patients, and you guys will have seen this too, a lot of patients will take aspirin. Okay, and it was a very good question about statin and heart failure. We'll come back to that before the end, but that's a very good question. So now let's look at primary prevention and aspirin. I always see patients buy aspirin. Like I work at Costco Pharmacy, and then the Kirkland, the Costco brand of the aspirin just flies off the shelf. It's like really, really cheap. And then when I talk to patients, I'm like, why are you getting this? They're like, I have high blood pressure. And I'm like, okay, so because you have high blood pressure, you're getting this. They're like, yeah, my risk of heart attack is higher. So my doctor said I need this. And I'm like, okay, well, why else is your risk of a heart attack high? I'm 60 years old. I'm like, okay, male. Okay. But the studies show if somebody did not have a heart attack yet, there is no benefit to using aspirin as prevention. Only as secondary prevention, there's a benefit. And when I tell patients this, they're like, what? Really? They just assume that if they have cardiac risk factors, that they should be on aspirin. But in fact, you only need it for secondary prevention. Omega-3s, they lower cholesterol. Like there's evidence, mixed evidence for that. But is there adequate evidence for use? No. But if a patient wants to try it, you can discuss the benefits that, look, there's limited evidence on this, but if you want to try it, it is something you can try. And then before we get to this, I would love to answer the question online. Why is a statin not beneficial for a heart failure patient? So what do you guys think? Let's rewind a little bit to what is heart failure. Heart failure is when there could be a pumping problem of the heart or a filling problem of the heart, right? We have two types of heart failure. Is it a filling problem? Is the heart having trouble filling with blood? Or is the heart having trouble pumping blood? That's what heart failure is. Heart failure is not due to blockage of the arteries, right? It's not due to atherosclerosis. It's not due to ischemia. There's no narrowing of the arteries or blockage that increases the risk of heart failure. Statins have benefit in preventing clots and things like that from happening. But because heart failure is not directly related to that, there's insufficient evidence to recommend a statin for patients with heart failure. It's because of the pathophysiology is not fully related. Does that make sense? And if not, you can tell me, Farah, that doesn't. Does that make sense? Very good comment, exactly. Very good comment. Makes sense? Yeah? And if it doesn't, you can say no. That's totally fine. I can explain it again. But it's because the pathophysiology of heart failure does not involve narrowing of the heart arteries or blockage. Good, very good question, though. There is a patient not having any heart disease, but he's just above 58 and wants to take aspirin, and he wants to take it just to prevent. If somebody wants to take it, they can take it, and you can say, this is how I say it. I'll say, you know what? There is insufficient evidence for primary prevention. But if it's something you want to take, you can, as long as you are aware. Makes sense? As long as you are aware of the benefit or no benefit, if they want to take it, that's okay. Very good. Now, going into secondary prevention or high-risk groups. So people with established cardiac disease, atherosclerotic, clot-related cardiovascular disease includes what's written on the slide: angina, myocardial infarction, stroke. These are all patients at high risk, okay? Established cardiac disease. Those without established cardiovascular disease, but who are at very high risk, includes those with diabetes and those with chronic kidney disease. Yeah, they don't have cardiac like ASCVD, but their risk is very, very high. Okay? And as we know, as patients get older, their risk goes up. When it comes to secondary prevention, lifestyle modification is an always, always, always. Usually in clot-related cardiac disease, in secondary prevention, we usually, and there's exceptions, but usually patients are on aspirin lifelong. Usually they're also on a statin. And then depending on other comorbidities, they may be on different things. Like if they had a STEMI or NSTEMI, they may need 2 antiplatelets. If they had a myocardial infarction, they may need an ACE or an ARB or a beta blocker. And this will cover more in detail when we talk about those conditions, as this is more high level. Patients may also require anticoagulants. Anticoagulants are different from antiplatelets. Anticoagulants are used more in atrial fibrillation. Okay, antiplatelets are used more in ischemic heart disease related to clotting. Sometimes a patient will have both a heart attack and AFib. So in some cases, we would have to use both. It depends on the scenario though, and that'll be discussed in the topic in class. And then you have your SGLT2 inhibitors. These are used in diabetes, but now they have emerging evidence for protective benefits and mortality benefits in those with heart failure. So those are an add-on, and same thing with things like spironolactone have also mortality benefits. Before we get to the case, I'm going to answer the three questions here. Regarding omega-3 for a patient that has cardiovascular disease, can it be taken safely? So it can be taken safely. Does it have adequate evidence? No, but it can be taken safely. But as long as the patient says, you know what, I understand that there is insufficient evidence, but as long as it's not going to kill me, I'll take it, that's fine as well. As long as the patient is aware to make an informed decision, they can take what they want, and you've provided that information to them. Where does AFib lie in the classification? AFib is a type of cardiovascular disease, but it's not a clot-related disease. So cardiovascular disease. Nope. Cardiovascular disease, you have heart failure, you also have AFib, and then you also have atherosclerotic cardiovascular disease, which this is myocardial infarction, which is stroke. Okay. And thank you to Ara for your explanation. All right, dear students, let's read this case together and then do just a couple of questions. YY is a 76-year-old female presenting to your outpatient cardiac clinic for a follow-up appointment. She suffers from diabetes, major depressive disorder, and hypertension. Her sugar levels fluctuate between 8 to 10. Her average blood pressure is 145/86. She's currently using metformin 500, sertraline, and perindopril. She has no known allergies. She lives independently with her dog, who is her constant companion. She is fully mobile and maintains her independence, managing daily activities on her own. So let's do the question.
So I popped up a poll for all you guys. You'll notice this is a bit different than all the other polls we've done. This is kind of a sample of an end of class quiz in the sense that you have more than one question to answer. So make sure when you are selecting your answers, you scroll down because there's a total of 4 questions. Once you've answered all 4 questions, then you can press submit, and then Farah will take up all the answers. So make sure you answer all 4 questions before submitting. We'll give you guys about 5 to 8 minutes, whatever Farah thinks is best, and then we'll go from there.
Yeah, let's give it a couple minutes and then we can review all of it together. You guys okay if we take it up? I think we're good to, let's take this up together. Let's do the first question. Let's see here. Awesome. Okay, so after the conversation with the doctor, YY is confused about his heart health. The doctor mentioned something about hypertension, the concepts of primary and secondary prevention. What is the most appropriate way to explain the difference? So let's see what you guys picked. There's a little bit of a mix, but majority of you picked the third one. So let's go through each option. First option, primary prevention is defined as preventing the occurrence of high cholesterol and high blood pressure. That's not true. So primary prevention is we want to prevent the occurrence of a heart attack, right? Those heart outcomes, the heart attacks and the stroke. High cholesterol, high blood pressure are risk factors, okay? And let's look at option B. Secondary prevention is preventing the occurrence of myocardial infarction in a patient with hypertension. So the wording here is a little bit tricky. Yes, we want to prevent a heart attack, but in this case, the patient's never had a heart attack before. So this patient only has hypertension. Because they only have hypertension, it would be primary prevention. We want to prevent the first occurrence. If they had already had a heart attack and they also have hypertension, then it would be secondary. And then let's look at the fourth option. Primary prevention is defined as preventing the recurrence of a myocardial infarction. So that's a play on words here. We're not looking to prevent a heart attack from happening again when we are defining primary prevention. That would be secondary. So to summarize, the answer is C. Secondary prevention is preventing the recurrence of a myocardial infarction, meaning it happened before and now it's happened again. So very, very good there. We can go to the second one. Which of the following statements is false regarding the difference between cardiovascular disease, atherosclerotic cardiovascular disease, ischemic heart disease, and other cardiac terms? So you guys did really good on this one. Let's take it up. So number one, cardiovascular disease is a broad range of conditions that affect the heart and the blood vessels. This statement is true. Remember, CVD is the umbrella, the tip of the umbrella. And then B, ischemic heart disease, also known as coronary artery disease. Remember, we talked about the clot, is cardiac disease where there's narrowing of the blood vessels. And angina is an example of that. So B is a true statement. Let's look at D. Atherosclerotic cardiovascular disease is a type of cardiovascular disease, correct? Because CVD is the tip of the umbrella, and then clot-related heart events are a subtype. Now, what about C? Ischemic heart disease is defined as any cardiac disease resulting from narrowing or blockage of the vessels, correct? But it's here it says such as heart failure. So that's the part that's not true because heart failure is not due to clotting. It's not ischemic in nature. So that is why C is the answer because the statement is false. We'll go to the next one. Given YY's medical history and current health status, should he be taking aspirin as part of the regimen? So let's take a look at your options. Let's start with A. A is saying that he should be taking aspirin, because he is high risk of developing cardiac disease. So in this case, yes, he is at risk of developing it, but we don't use it in primary prevention. This patient has not had a heart attack before, so we are still in that primary prevention stage. So we don't need the aspirin. That's why A is false. B, no, he should not be taking aspirin. It's true he shouldn't, but the reason is not the most appropriate reason. Yeah, aspirin, sertraline, risk of bleeds, but that's not the right reason in this scenario. Because even if he has a risk of bleeds with the sertraline, we would still be able to use the aspirin if it was indicated with monitoring and evaluating the risk and the benefit. Let's look at C. Why should we be taking aspirin? Because the blood pressure is uncontrolled. That's not true, because aspirin is good for secondary, not primary prevention. So let's look at D. No, why should not be taking aspirin? Because he has no history of atherosclerosis. Exactly. So no history of clots. We are not in secondary prevention. We're in primary prevention. So that's why he doesn't need to. Very good. And we can move to the last one. Given YY's medical history and current health status, should he be prescribed a statin? So you guys did great on this. Let's go from the top. YY should be taking a statin because he has a history of atherosclerosis. No, he has no history of like MI or stroke or anything like that. So A is false. B, no, he should not take a statin because he has no history. So yes, he has no history of atherosclerosis, but he has another indication for the statin. Let's look at D. YY should not be taking statin because it can worsen depression. That is not an appropriate statement in this case because he has a reason for the statin, which leads us to C. Since he is over 40 years of age and has diabetes, he should be on a statin because he is at higher risk. There we go. That was great. So guys, how do you feel about the questions? How did you feel about the therapeutics? Are you feeling okay? Just want to check in. Does that make sense and clarifies the concepts for you? Yeah. And if it doesn't, you can tell me and we can clarify some things for you. Yeah? Okay. That was really fun. I feel so bad it's late for you guys, but that was really, really nice. I will pass it back to Parmeet.